everybody. Welcome to another episode of the Atlantic Still podcast. I'm here with a person I've heard wonderful things about, and I'm excited to finally get to do this with him, John McLernon, who has an outstanding background in social services and addiction. And I just want to get this started right away by letting him introduce himself.
Thank you, Donald. My name is John McLernon. I'm a licensed clinical social worker. I practice out of Northfield. I have a small private practice. I was a former director for the Department of Family and Community Development for Atlantic County, working with homelessness and individuals at risk of being homeless, most of whom were mentally ill and or substance dependent. And I also worked at the Atlantic County Jail for about 8 years in the same role, helping inmates come in, exit to the community, and also while they're incarcerated, we did a lot of treatment in terms of treating people with substance use disorders as well.
That's awesome. So that's what I really wanted to focus on today's topic, substance use disorder and addiction. So I'm just going to throw the floor to you. What are some things you wish people knew when they're dealing with people with addiction or living with people with substance use disorder? Kind of what is the one thing you wish that people would understand more?
That it's really not a choice. And unfortunately, that seems to working with a lot of family members. Family members get very frustrated because they believe their loved one is actually choosing to, stick a needle in their arm, if it's opioids and intravenous use, or guzzle down vodka, if it's alcohol is the drug of choice. But truthfully, it really is the neuroscience of addiction. The brain is simply craving it so desperately and so badly that level of comfortability in the person is so intense that they typically just fall vulnerable to going back to the drug because it's the only substance that gives them a sense of normalcy after a while. So many years their brain has been conditioned to having that drug. So I think a lot of parents and loved ones, partners, husbands, wives are led to the belief that this person just woke up in the morning and is choosing to go back to the drug that had got them impaired. But if you think about it, I mean, who would want to return to a life if your life on substances is causing all this distress, like going to being incarcerated, being evicted, losing jobs, losing relationships, going through extensive litigation during divorces? Who would realistically want to follow that life? I mean, you're not following a glamorous life. You're talking about a life of desperation, heartache, and simply a lot of emotional pain. So to answer your question, Donald, it would probably be trying to educate parents that your loved one really does have a brain disease.
Yes, and I think that's a real important point because people do. I mean, there's been some progress in that area, but you're right. People think it's like they could just turn off a light switch, like, oh, just don't drink or just don't use the substance that's making you addicted. But it's more complicated than that. And how much of addiction is genetic versus kind of learned behavior? Can you speak on that? Like, how much control does somebody really have?
What a great question. There's been an enormous shift in the causality theory as to what really does cause addiction when a person consumes alcohol or other drugs. So you're right. It was a genetic model for many, many years. At one point, we used to be able to say, well, Bobby's mother was alcoholic and his father was also alcoholic. So clearly Bobby's going to turn out alcoholic because he's inherited those genes from his mother and father. And as time marched on, it's taken a more of a evolutionary approach, meaning that the causation and causality is typically looked at like a child in a family where alcohol is used pretty freely and liberally, that what the person does is really just kind of mimic the behavior of the mother or the father or whoever else is living in the household. So there's more of a stronger concentration at looking at family history, not so much from the genetic concept, but more so from the concept of just being constant exposed to alcohol being the drug of choice, if that is the drug. Many families use alcohol in addition to a multitude of other drugs. But it's less and less emphasis on genetics and more emphasis on learned behavior. So it's pretty interesting as that kind of model has changed, because in 1957, when the American Medical Association declared alcoholism a disease, it was very, very controversial because up to that point, people saw it simply as a mental health disorder. Who would guzzle, a quart of vodka and in the range of normalcy that someone would do that and would get completely impaired and not go to work with 3 children and a wife that was caring for the family. So the concentration really was on men at that time in 57 when the AMA said it's a disease. But if you really read the extensive research behind that, many of the physicians that voted for that still didn't quite see it as a bona fide disease. They still saw it as a mental health disorder. The reason why the AMA did that was they wanted men at that time were the heads of households, and very few women were working. If there was a relationship, the women were typically caring for the children. So as a result, the AMA was trying to get men to go into treatment. Specifically at that time, Alcoholics Anonymous was the first line of choice, just kind of, if you will, save the family. So as time marched on, as I mentioned, the evolutionary process and kind of the learned behavior model became much more prominent. So when you talk to people today about what they think caused it, they'll tell you typically anxiety and depression or uncontrolled depression or uncontrolled anxiety, but you have to go one level closer after that to determine like what's causing the depression, what's causing the anxiety, and probably 7 out of 10 times there's some level of trauma. And you got to remember, Donald, trauma can be measured much more than just physically assaulted. It can be sustained neglect as well. So children that have been neglected over a long period of time, for example, typically exhibit substance use disorders behavior. And as a result, it's just simply being neglected, because if your parent or the person who's assigned to care for you is not expressing any love and support, it's a very dark place to be. And alcohol and other drugs fills that hole.
That's a great point. I love that point about trauma, because people do define trauma quite narrowly. I'm sure you meet people that go, actually, my house was fine. There was no physical violence or anything like that. But then, like you say, you got to dig a little deeper, and maybe they felt disconnected from their caregiver or parent or whoever that is. So, and I loved your point. I loved all this, but about, I think it's important to remember that people are using substances to cope with something usually. They're not just doing it for fun. They're doing it, because there's some sort of anxiety or something going on. So that's important to understand too. Like I think sometimes you hear people go, I don't understand why anyone would use those substances. But like, at least in my experience, if you talk to people who are having those issues, it actually does make sense why they would use it. It's certainly not the best thing for them to do, but it's pretty logical. Would you agree with that? Like, it makes sense. They're trying to deal with something.
Yeah, I think the non-addicted person or the individual that doesn't understand addiction is very baffled by the concept of, like, why would a person with a cirrhotic liver, a liver that has cirrhosis, the person would be in danger of dying if they injected more toxins into their body, but yet they do. So, obviously some people would be very baffled by that and saying it absolutely makes no sense. It's illogical. These individuals need to be committed. They've lacked the capacity to make good judgments. But yet, if you think about the brain disease concept again, the brain is craving these drugs. More so than, like, it overrides all logic and reasoning that anyone can think of. The brain is the central organ in our body that actually controls, of course, what we do. But the brain is craving it, and it wins. And so the person succumbs to the alcohol. I'm just using alcohol as an easier example, because there's many other types of drugs that people are dependent on other than just alcohol. But the person will just crave the drug because it brings them back to that sense of normalcy again. It calms them down. It gives them that equilibrium that they're searching for the entire time. They feel kind of like disconnected if they don't have the drug in their system.
Right. In that short term, it allows them to function. So what would you advise? Go ahead.
No, the short term, but what's really interesting is that even the treatment models are kind of following different ways of getting well now. For years it was you had to be abstinent from the drug. And now what you're finding is more and more rehab centers are including harms reduction as another method of getting well. So if someone really can't abstain from the drug or has tried multiple times to go into an abstinence-based model to remove the drug completely from your system, like methadone is a really good example of what's used as harms reduction for individuals who are dependent on opioids for their drug, and that gets very, very baffling after a while as well.
So harm reduction would be just not, just so people understand, just not doing it like cold turkey. Like, I don't know, how would you explain it for people who don't know?
Yeah, let me explain it. So the example I gave with regard to, I think the methadone with an opioid would be the better example, because really what you're doing with methadone is you're giving a person who's addicted to heroin a synthetic opioid. I mean, methadone is equally as addicting. It makes no sense to the average person on the street, because why are you giving the person another drug which is equally as addicting as an opioid? And then the reason is because you're quelling the brain's quest to get the drug in the system. The person can actually function on methadone. They can go to work. They can earn income. So you're delaying or preventing any level of homelessness. The person can be gainfully employed, so the person has a private insurance plan that can continue. The relationship, can flourish and prosper because the person can function very well on methadone. But unfortunately, the downside of that is the person is dependent on the methadone. They would have to go into a detox to come off the drug. But many people now are staying on methadone 5, 10, 15, 20 years because they're finding that they just couldn't abstain from heroin or other opioids, and they couldn't function without it. They just could not function. So harm reduction is becoming more recognized as a bona fide treatment program.
All right, well, that makes sense. And that's, and that's part of, I think, kind of like what you talked about with the history, the evolution of our thinking of not only is this a disease, but maybe quitting it cold turkey isn't the best option for a lot of people, or a realistic option for some people, and that maybe you got to work with what you have a lot of. You brought up opioids, and you're right. I know we were talking about alcohol, but I know that especially in the last 20 years, 10 years, we've had a serious opioid addiction crisis in this country. And as somebody who's worked in this field a lot, I wanted to kind of ask you your thoughts on that and see what you think about kind of how that all happened, like the evolution of that, and what your experiences has been dealing with this country's situation with opioids.
Well, unfortunately, there is no more heroin on the streets. When I say unfortunately, I'm not that I'm pro heroin by any means. But what I am saying is that it's all fentanyl now. So the danger is when someone buys what they think is heroin, invariably it's fentanyl, which is a very, very, very potent opioid. It just happens to be very, very cheap. So that's why it's being imported from a multitude of different countries and being funneled into this country. When you talk to the people that buy heroin on the street, they try to take a small chip of the drug now because they know how potent it is. But it's like gauging a dosage when you have no idea how potent the drug is from the first place. But it's not heroin anymore. It's unfortunately fentanyl, and that's happening with synthetic drugs that people are buying off the web and things like that. They're filled with this toxin called fentanyl, which is such a strong, very, very, very potent opioid. It's just that it's so cheap to manufacture. That's why it's being substituted for heroin. So you can get the euphoric effect, but many people, unfortunately, will die and overdose because there's no dosing instructions, of course, that come with a street drug. But more importantly, you have no idea how potent the drug is because there's nothing to compare it to anymore, because it's a drug that we're not accustomed to seeing, but it's saturated in this country at this point.
Yeah, and this brings an interesting topic, somewhat controversial, but I wanted to get your opinions on it because I read a lot and I think about this. Like, what are your opinions on kind of drug policy, like legalization versus kind of the war on drugs? And has that been counterproductive? And would legalization or decriminalization be better? Do you have any thoughts on that? And if you don't, I have six more other questions.
Very strong thoughts on that. If you look at some of the European countries, and particularly the Scandinavian countries, Sweden and Norway have really, and so has Great Britain. I mean, they've led the fight against drug addiction by simply normalizing it. They recognize that someone who's addicted to opioids is going to probably commit multitude of crimes, a multitude of stealing taking place, a multitude of maybe physical assault in order to get someone's wallet or pocketbook or purse, a lot of stealing, just in theft in general. So they've noticed that when they actually give away the drug, and the way that's simply done is if you're an opioid dependent person, you would go to your local pharmacy in one of those countries. You're already been pre-registered. you would get the dosage that you were at when you first tried to stop, and you'd also get a free syringe. And you would do that every day. You would just come into the pharmacy and pick up your drug and shoot it because it would satisfy your brain's needs. Now, the downside is that people are saying you're promoting, encouraging drug addiction, and I'm certainly not encouraging it. The person's already pre-addicted. But what the upside really is that crime goes down by 700%. Assault of crime, crime against individuals, crime against children, just crimes in general just go down. It's remarkable because people aren't stealing to get the drug because it's given to them. And It's just a good investment. It's good policy.
Right. It's a good trade-off if you're going to make the trade-off.
It is. I mean, you got to remember that crime is going down. So other people who are not addicted are not adversely impacted by individuals that are out there trying to scrounge up the money to buy another bag of dope. They can go to the pharmacy, get it for free, and they know what they're getting. They're not getting fentanyl. They're actually getting heroin. So the person can function on it. Yeah.
That's a great point. And it's probably less stigmatized because it's just more regulated and more, not accepted by society, but less punitive by society is a better way to put it.
That's a good way of phrasing it, Donald. It is less punitive. I mean, European countries are actually decades ahead of us in terms of progressive thinking on a multitude of different topics as well. So it blends in very, very nicely with their culture. And no one sees the addicted person as being flawed or disordered. They just see a person struggling like the rest of us are struggling to get through another day sometimes.
Right, which I think is key. One of the things that I wanted to touch on that I like that you brought up, like I said at the beginning, was kind of the importance of mental health in addiction. So is that really the source of a lot of people's substance use issues?
Yes.
That's the key to it, really, unlocking good mental health.
You're not assessing for depression and anxiety and other forms of mental illness when you're doing a substance use evaluation. Then you're actually incompetent in what you're doing. You really need to include those factors because an 8-year-old or a 10-year-old just doesn't grow up and frankly just want to drink a beer. There's a reason for why they had that first beer. Now, it could be curiosity in the beginning, but after a while, when dependency takes place and they just keep, drinking and drinking despite the consequences, then obviously something is triggering that. And unless you explore what that is, you're not going to treat the substance use disorder.
Yeah, I think that's so key. And I think, we talk a lot about mental health, but it really is the key to everything, to dealing with everything. It's kind of the beginning of everything, and if it's not handled correctly, it leads to a lot of issues. And can you talk about still the stigma that surrounds mental health? I feel like we still treat, if I had I have cerebral palsy. If you have a physical thing, people are more still tolerant about it. But if you have a mental thing, people still use that very punitive, get over your depression, deal with it, stuff like that.
Extremely common. It's so interesting. When I talk to people in the office about their medication, they're very open in talking about the antihypertensives to control blood pressure or diabetic medication to control diabetes. But if you say something like, should I call your primary to consider maybe a serotonin uptake inhibitor to treat the depression, they back off very quickly and they'll say, well, that's for mental health. That's a mental health medication. It's it's psychotropic. So it's a classification. It's called psychotropic medication. It's so interesting because the people will look at you like, do I look crazy to you? It's like, no, not at all. You look like a person that's going through depression. That doesn't make you crazy. It just makes you having a chemical imbalance that's being caused by something that we have to search a little further to define. But when you go into those classifications of medications that might be beneficial for the person, it's remarkable. They just feel very, very judged almost for a moment. Like, am I really that bad? It's like, no, you're symptomatic of depression. Just like if you fell on the floor and you broke your arm, you'd be symptomatic of pain from breaking your arm. It's along the identical same process. It's just a different medication to treat something very different. Just because you can't see depression doesn't make depression any less severe.
Right. And nobody would say, what's wrong with you for breaking your arm if you went to the hospital? Like nobody, like it's just weird how culturally we
Yeah.
we view certain things. So what should be if you have somebody you love with addiction or substance use issues, how should you handle that? And how much of it, and it's the tough question too, how much of it is really your uh, like how much can you really do? Because I think sometimes we overestimate kind of those of us on the outside the impact that we can have sometimes. Like if I just
Well,
said this or if I just finished this, yeah.
well, you can always start with your primary. I'm big at contacting primary physicians all the time. I just think if you're treating someone, whether it be depression or anxiety, that you really need to involve their primary, so that when they see their physician, you can that person is aware that they have either depression, anxiety, or a multitude of other disorders, so that that the medication is being prescribed to help reduce the symptoms, so that there's this whole coordinated effort to help the person get well, not just splintered in one direction and the other person's not privy to what's taking place. But I wanted to emphasize, Donald, that there's a lot of public subsidies out there for substance use disorders. Like when I worked for the county, I was really we get a lot of Chapter 1, what's called Chapter 51. Chapter 51 money is money from the Division of Addictions in Trenton that pays for detox treatment and rehab treatment for any individual that's simply low income. And low income is very broadly defined. Like you won't see a set of numbers that you have to fall into. If you make the call and that if the person doing the assessment, understands that you're just simply low income, then you're entitled to get one of these subsidies. And that would pay for the entire treatment, including medical detoxification, all medical care, up to including 20 to 25 days in inpatient as well. And then it would also pay for the aftercare coming out, going to maybe intensive outpatient or doing groups, for example, along with a certified alcohol drug counselor. So there is a lot of money pumped into it. In fact, I've been asked to be on a committee with the county starting August the 5th. The opioid money is trickled down from all the lawsuits against the pharmaceutical companies that were pretty liberal in convincing doctors to dispense opioids to people. There's a lot of money that's coming down to all the counties and states. So, the job of the committee is going to be how this money should be spent, most wisely to help individuals of Atlantic County that are adversely impacted by opioid dependency. So there's another whole source of funding coming down very shortly, which will be distributed to the counties and the cities and the states, which is very exciting because, no one, there'll be no answers. That no one will have to listen to. There is no funding available. No one should have to listen to. I can't afford it because it should be affordable because of all the subsidies. Even in the welfare system, people on public assistance receiving like general assistance, single people who are receiving public assistance, and mothers and fathers with dependent children called TANF, TANF, Temporary Assistance for Needy Families. The counties all have a lot of money for both behavioral health and substance use abuse. So if we recognize, for example, that someone in the Work First New Jersey activities, and welfare today is called Work First New Jersey in our state, because it's all about getting the person to go to work if they're able to go to work. So if one of the barriers might be substance use, or what the other barrier might be mental health, depression and anxiety specifically, there's free treatment by licensed clinicians. I mean, the GA worker, which is the general assistance worker, like in Atlantic City, would just simply make a phone call to Pleasantville and would schedule that person for an evaluation, which would be in a couple of days. That person would go in and get a full treatment, for the next 30 days on how to get off the drug, how to stay off the drug, and more importantly, how to function back into life, up to and considering working if in fact they have the capacity to go to work. So the same applies for the behavioral health side of it as well. Someone is experiencing some diagnosis or some type of symptom which precludes them from participating in work first activities. Then they're going to actually be deferred, and they won't have to participate, and then they'll be taking the permanent disability route. So we'd be going the SSI route or the SSD route to help that person stabilize. So it doesn't always have to be work, but you first have to demonstrate, or the clinician has to demonstrate or suspect that there is some serious disability that would preclude the person from working, and then we would go the route of helping the person get on permanent disability.
Well, that's a great point, John. So there are a lot of resources available, and I think sometimes people don't know it. And like you said, there's always people are used to those answers, and there's not funding for that at this time, or there's funding, but the wait list is closed, like all those type of answers. But there are resources out there now. So what should a person do if they're looking for help? Should they just call the county social services building?
That's such a great question, because I get that all the time. I would say if the person has a primary physician, then they on the back of their card is a toll-free number. They can just call the insurance company, even if it's Medicaid, and ask Medicaid to send them a list of all the providers who accept Medicaid that treat whatever the disorder is they want to get treated. So that might be the first step, or speak to their physician. Usually the physician has a list, or the PA has a list. The larger healthcare centers like Atlantic Care, and I include Jewish Family Services in that because it's a very large organization that does a great job in helping persons who are at risk of homelessness and also who are also experiencing homelessness. They too also have outpatient care in their offices in Margate, and Atlantic Care has at least in a dozen locations throughout Atlantic County. They have outpatient. So if you were to call like at their access center, which is 609-646-9159, the Atlantic Care Access Center could put them in contact with maybe the Federally Qualified Healthcare Center, which is a federally funded clinic, which many physicians and PAs and APNs work in to provide not only primary health care, but also behavioral health and substance use at absolutely no cost at all to the patient. They'd also get the person on Medicaid so they can continue their treatment and maintain a true kind of continuity of care. So there are a lot of subsidies out there that I think people just don't think are there. It might take a couple phone calls, but they will get there if they just remain a little bit persistent.
Yeah, that's a real key, John. I know it's tough for people, especially when you're dealing with substance use, but as somebody who's dealt with government agencies and a lot of things, I think persistence is really key. You got to keep advocating for yourself the best you can, and there are a lot of resources out there, but you got to make that phone calling and not only ask for help, but continue to follow up to make sure you get it. And I know that's a lot more easier said than done, but that really is key, I think.
Well, you can also contact the county offices at 345-6700 and just ask the operator for like the substance abuse unit or the mental health administrator, and those individuals would easily be able to guide the person directly to a direct care as well. So although that's limited to Monday through Friday, there is a 211 number that was administered by United Way. That it's just an informational number that people will look up names and addresses of organizations that can better assist the person depending upon what they're looking for.
Yeah, and that's a great point. And what about that's a great strategy for somebody who's going through something. What about somebody in a situation with somebody who's got a substance use issue, their loved one has a substance use issue, I'm sorry, but they're not interested in getting help at this point. What would be your advice to that person?
Yeah, that's very common, by the way. I get a lot of calls from mothers and fathers, that want their adult child to get well, but the adult child doesn't want to get well. So what I normally would do is I would talk to the person who is adversely impacted if they'll talk to me. And it's a very gradual process of just using a motivational interviewing technique to try to get them to be a little more engaged. If I can get the person just to try meeting with one person or just two people, schedule an appointment for them, that it's sometimes it works out really nicely that the person just feels like someone really cares about me, and they'll check into treatment, particularly when they realize that they don't have to pay anything for it and it is completely free. But you're right. That's always a difficult thing. If the addicted person absolutely unequivocally says, no, I'm not going, you can't do it, you can't make me, they're probably right. You can't really make a person go to treatment, and they're not going to benefit from that if they really are not motivated to go. But that is a perplexing issue that I face all the time.
Yes. You
Just
know,
keep trying.
keep trying because you might break through eventually. Oh,
Yep.
so,
Yep. Absolutely.
yeah. Thank you for being with us. I'm going to wrap
My
it up
pleasure.
here. Do you have any closing thoughts on addiction or anything like that? Anything you want people to take away from this kind of the main point?
There really is treatment available, and there's so much money available in this country for addiction. There's so many facilities in our county accept public subsidies. That all the person has to do is say, I'm low income, I can't afford it. Pyramid, which is a rehab in Hamilton, is 99% of all their patients are Medicaid. And we used to work the streets of Atlantic City, a group of us that was trying to reduce the number of opioid dependent people. So we walked in some really blighted areas of Atlantic City at nighttime and ran across a lot of people literally with needles in their arms. So the county was able to let me use a cab service to get people into treatment. So we were able to get them on Medicaid pretty quickly, and then had them transported by cab to the rehab in Hamilton. And then at that point, they begin to like a 21-day stay of detoxing and rehab. But the money was there through Medicaid. But you have to spend about an hour with that person just to get the Medicaid application going. And once you do, they're good for a couple of years.
All right, so that's
most facilities like Atlantic Care, they'll do the application for you.
yes, and that's cells help with applications. That's a great takeaway. There are resources out there. You just have to avail yourself of it, and there is help out there. There are options that you have.
There are.
All
you
right,
don't
well,
have to suffer.
Thank you, John, for joining us. This was great, and I really learned a lot. So thank you so much.
My pleasure. Thank you for having me.
All right, bye everybody. Until next time.